Hi, my name is Ashley Spetter, and I'm a student with the BSN program at McKendree University, and I'm going to be doing a cardiopulmonary assessment on my patient today. I'd start with taking a health history on my patient, see if he had any history of cardiopulmonary issues, any history of asthma, stroke, high blood pressure, any kind of heart and lung issues. I would take history of his diet and exercise, stress level, and then I'd also take a family history of any kind of cardiopulmonary issues. The next thing I would do is take a blood pressure on my patient. And his blood pressure is 116/70. And then I would take that pressure in both of his arms, and I would do that in a lying, sitting, and standing position just to evaluate for any changes in the pressure with the change of positions. Then I would listen to his heart and take his pulse rate. And while I'm taking his pulse rate, I would listen for any kind of abnormal sounds, any kind of rubbing or murmurs or anything like that. And his pulse is 84, and it was strong, and the rhythm was normal. I didn't hear any kind of strange sounds, any kind of murmurs or rubbing, anything like that. The next thing I would do is have my patient lay down. And first I would do an inspection of his chest, see that it's symmetric, see if I can see any visible palpation, see if I can see the PMI. I'd also, while I was inspecting that, I would inspect his respiratory effort, the rate, see if he's using any intercostal muscles to breathe, make sure that his breath sounds and respirations look normal. So then the next thing I would do is palpate the chest for any kind of abnormal feelings or anything in the valvular areas. So I would begin with the aortic area, which is on the right, second intercostal space, and then the pulmonic, which is the left, second intercostal space with the sternal border, and then the tricuspid, and the mitral area. And then I try to feel for his PMI. And then I would auscultate the patient's heart in those areas to see if I heard anything abnormal, and listen for S1 and S2 in the aortic, pulmonic, tricuspid, and mitral areas. And I'd also listen for the PMI, make sure that it wasn't displaced. And again, I don't hear any murmurs or clicks, and I don't hear any S3 or S4 sounds, so that is good. The next thing I would do is palpate his pulses. I would palpate all of the pulses. I'd start with the temporal area, then the carotid, feeling them one at a time. Then his brachial, radial, ulnar. Would also palpate femoral pulses, and then I palpate his popliteal pulses behind the knee, his posterior tibial pulses, in his ankle area, and then his dorsalis pedal pulses on the top of his foot in both areas. And all pulses are +2 and normal. And then I'd auscultate for bruits over the temporal and carotid arteries with the bell of my stethoscope. And no bruits are noted. Next I'm going to have my patient sit up for me. And I inspected his chest earlier for his respiratory effort, make sure that the chest was symmetric, all those sort of things. And the next thing I would do would be count his respiratory rate. And it is about 20. So the next thing that I would do is palpate his chest, see if I feel any crepitus, any bulges or masses, any pulsations that seem to be abnormal. Then I'd inspect his trachea, make sure that it was midline and movable. And it is. And then I would auscultate for tactile fremitus. Feel for tactile fremitus. Say 99.
99.
99.
99.
And again.
99. 99.
And if you can feel the vibration in the chest, that is normal with tactile fremitus. And the next thing I do is percuss. I would percuss over the lung fields. Making sure I heard resonance, percussing in between the intercostal spaces. Make sure I didn't hear any kind of dull sounds, which would suggest areas of consolidation. And then the next thing that I would do is listen for bronchial sounds over the trachea. Then bronchovesicular sounds. And then the rest of his lung fields with the vesicular sounds. Listening to the front and back. And I didn't hear any adventition sounds, no crackles or wheezes, no stridor, nothing like that was noted, no rubbing. And then I would evaluate for bronchophony, egophony, and whispered ventriloquy. So an example of that would be, can you say E for me?
E.
And again?
E.
And again?
E.
And again?
E.
And those sounds sounded like E. If there was some areas of consolidation, it would sound more like an A sound. And then an example of whispered ventriloquy. If you'll whisper 1, 2, 3, please. And again. And again. And again. And I couldn't hear any of those sounds through my stethoscope, so that's good. If I could hear the 1, 2, 3 loudly through my stethoscope, that would mean that there might be some areas of consolidation. So that concludes a cardiopulmonary assessment on a patient. I would summarize my findings in writing in the chart, and thank you very much.